thank you for joining us on the ACEP Capital Minute, a biweekly look at the latest developments from the nation's capital that impact emergency physicians. I'm Laura Wooster. After my update, we'll open it up for questions. You can submit them at any time by using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live. So today we'll cover a legislative update about psychiatric patients, trauma, violence, and suicide screenings, a regulatory update about surprise billing, buprenorphine, new ambulance provider guidance, and an advocacy update about scope of practice activities and LAC. Last week, the House approved 3 ACEP-supported bills related to psychiatric patients boarding in the ED, trauma, violence, and ED suicide screening. HR 1205, the Improving Mental Health Access from the Emergency Department Act of 2021, sponsored by emergency physician Representative Raul Ruiz of California, would establish grants in support of creating or expanding follow-up services for people who need care for acute mental health emergencies. HR 1260, the Bipartisan Solution to Cyclical Violence Act of 2021, sponsored by Representatives Dutch Ruppersberger and Adam Kinzinger, would create a grant program at HHS to support trauma centers with violence intervention and violence prevention programs. This would also support research aimed at reducing re-injury and reincarceration associated with intentional violent trauma. HR 1324, the Effective Suicide Screening and Assessment in the Emergency Department Act of 2021, sponsored by Representatives Gus Bilirakis of Florida and Darren Soto of Florida, would create voluntary grant programs to improve the identification, assessment, and treatment of patients in the ED who are at risk for suicide. This bill will help develop policies and procedures and enhance the coordination of care after discharge for these patients. Together, these 3 pieces of legislation are strong examples of how many elected officials in Congress rely on expertise from ACEP to make sure that complex health challenges are met with sensible solutions that work for both patients and physicians. Last Thursday, the House also passed HR 2547, or the Comprehensive Debt Collection Improvement Act, sponsored by Representative Maxine Waters of California. The legislation is a package of consumer debt relief provisions. The bill includes language that would prevent medical debt collection for 2 years from the date of the first bill, includes a 1-year delay before adverse information is reported to a consumer reporting agency, and would ban reporting of debt that results from medically necessary procedures. ACEP will continue to monitor this legislation and any potential implications for patients and physicians, but for now, publicly, we are remaining neutral. We should also highlight the reintroduction of the ACEP-supported Coronavirus Provider Protection Act, or HR 3021. On May 7th, Representatives Lou Correa, a Democrat from California, and Dr. Mike Burgess, a Republican from Texas, reintroduced this bipartisan bill to provide limited and targeted protection to ensure that healthcare professionals and facilities who have served on the front lines of the coronavirus pandemic are not drawn into unwarranted lawsuits related to COVID care. This legislation reflects the recognition that a comprehensive federal solution is necessary rather than a patchwork of state initiatives, which is what currently exists today. This bill would reduce lawsuits that could result from the healthcare workforce shortages, inadequate safety supplies, and changing guidance from federal, state, and local government officials that were typical in the early stages of the pandemic, especially. At the same time, it would maintain necessary mechanisms to help patients harmed by substandard care. On the Senate side, there are several hearings that ACEP is monitoring closely. Last Tuesday, the Senate Health, Education, Labor, and Pensions, or HELP Committee, held a hearing to receive an update on efforts to combat COVID-19 that included witness testimony from Dr. Anthony Fauci, as well as leaders within HHS, FDA, and the CDC. Dr. Peter Marks, the director of FDA Center for Biologics Evaluation and Research, and Dr. Rochelle Walensky, director of the CDC. That same day, the Senate Judiciary Subcommittee on the Constitution held a hearing entitled Stop Gun Violence, Ghost Guns. Witnesses included the Commissioner of the Baltimore Police Department, the Pennsylvania Attorney General, and several leading policy experts and safety advocates. A hearing held by the House Energy and Commerce Health Subcommittee discussed the fiscal year 2022 HHS budget and featured only one witness, HHS Secretary Javier Becerra. Representatives Raul Ruiz from California and Dr. Larry Bouchon from Indiana seized the opportunity to urge Secretary Becerra to make sure that the congressional intent of the No Surprises Act is followed during the ongoing discussions about regulatory implementation. Both lawmakers also expressed a desire for CSIO, the group within CMS that is holding the discussions about the surprise billing law's implementation, to issue the rule in a manner that will allow for a full public comment period. Lastly, the Senate Finance Healthcare Subcommittee held a hearing to examine mental health and addiction services in communities. Witnesses included state health officials and practitioners. During the hearing, Senator Catherine Cortez Masto of Nevada raised the issue of behavioral health emergencies and how to provide better access to mental health treatment for these patients. ACEP is actively engaged in discussions with regulatory officials about proposed regulations, how best to implement legislation, and how to strengthen data sharing, among other topics. Despite not yet having an officially confirmed leader, CMS continues to be quite busy. During the previous Capitol Minute, we discussed the Biden administration's updated buprenorphine practice guidelines. You may have even seen our press release on this topic that was posted at emergencyphysicians.org. While there are still some hurdles to access, this is a step in the right direction. The main point is that the X waiver still exists, but the need for an 8-hour training course to receive one has been eliminated. When the new guidelines were announced, there were questions, though, about whether emergency physicians would be included in the group of practitioners who treat more than 30 patients at a time and would therefore still need to complete the training course and not be kind of exempted from that to get an X waiver. We have determined through conversations with HHS that once you refer a patient for treatment or stop managing a patient's buprenorphine prescription, the patient is no longer considered under your care and would not count towards the 30 patient limit. What this means is that you as an emergency physician can qualify for the exemption without any restrictions and therefore do not have to do the 8 hours of training that are required to get an X waiver. ACEP and the Emergency Department Practice Management Association, or EDPMA, has sent our second follow-up letter to federal agencies implementing the No Surprises Act that includes technical feedback on key billing and administrative processes that need to be thoroughly addressed in the regulation on surprise billing. I'm sure everyone remembers that for the last 2 years, ACEP has worked to ensure that any legislation to address surprise medical billing would truly keep patients out of the middle of billing disputes and include a fair payment mechanism that holds health plans accountable and ensures adequate reimbursement for out-of-network services. We continue to believe that the No Surprises Act was a reasonable solution, and like any major piece of the legislation, the details of the bill need to be sorted out through the long regulatory process. Together, ACEP and EDPMA will ensure that the message from the emergency medicine community is loud, clear, consistent, and timely. Our feedback to the agency started with a 19-page letter in late March that summarized our recommendations on core aspects of implementation of the No Surprises Act. A summary of this letter is available on the ACEP Regs and Eggs blog, as well as on our federal advocacy page on acep.org/federal-advocacy. Last week, ACEP responded to a proposed regulation released by the Office of Civil Rights within HHS that would make changes to HIPAA. The proposed regulation was released last December under the Trump administration, but now the Biden administration gets to decide whether or not to finalize it. As you well know, HIPAA is complex to say the least. Our letter communicates to OCR that it is reasonable to assume that physicians and hospitals are still navigating the new data sharing regulations instituted by the Office of the National Coordinator for Health Information Technology in early April. In short, we don't think this is the best time to modify HIPAA on top of that. Our response letter supports some of the policies that we believe reduce administrative burdens or enhance patient care. However, we also express concerns about proposals that would jeopardize the privacy and security of patients' health information. We've requested that OCR avoid finalizing a proposal to relax restrictions on personal photos or videos taken by patients of their health information or create an exception for the ED. Another proposal would shorten the time frame for required response to health information requests. It's easy to imagine that compliance can become difficult during emergencies or disasters, and we've requested an exemption there as well. We will also work to make sure that requests for information by health plans do not lead to discriminatory reimbursement models or intrude on physicians' medical decision-making. A more detailed summary of our response letter is available on the ACEP Regs and Eggs blog at acep.org/regs-and-eggs. There are new federal requirements around the access, exchange, and use of patients' electronic health information, as I just noted. ACEP is taking proactive steps to help our members implement these requirements and identify any necessary regulatory changes within the Office of the National Coordinator for Health IT that's within HHS. CMS released guidance on new hospital conditions of participation last week that require hospitals using electronic medical records to send electronic patient notifications for admission, discharge, and/or transfer to post-acute care providers and to any practitioner a patient considers primarily responsible for their care. According to the guidance, a hospital's electronic system must send electronic patient event notifications at the time of the patient's registration in the hospital's emergency department, upon admission to the hospital's inpatient services, if applicable, and immediately prior to or at the time of patient discharge and/or transfer. CMS has also posted FAQs on the guidance on their website. In anticipation of all these changes, after meeting with ONC back in March, ACEP created a poll to assess our members' feedback on the data sharing requirements. We received more than 130 responses to the poll and will be summarizing them for ONC and others. Preliminary poll results show that ACEP members have real concerns about prematurely sharing data with patients before physicians have an opportunity to review and discuss results with the patients. More information for members about the results of the poll will be coming in our next Capital Minute, so stay tuned. For our EMS colleagues, CMS issued a waiver that allows Medicare payment to ambulance providers for treating a patient in place without transporting the patient during the COVID-19 public health emergency. The waiver allows those treating patients in place to be reimbursed at the same rate as those who would have transported the patient under different circumstances. This only applies when the ambulance is operating under a community-wide emergency medical service protocol that requires or allows, with patient consent, an ambulance provider to treat in place a patient who otherwise would have been transported to a hospital. This waiver is only temporarily and will expire at the end of the COVID-19 public health emergency. CMS just released new data on healthcare service utilization by Medicaid and CHIP beneficiaries between March to October of 2020. Among the key findings, this report reveals that many children on Medicaid appear to have skipped critical healthcare services during that time. Compared to the same period last year, there were fewer vaccinations for children up to age 2, fewer child health screenings, fewer mental health services, and fewer dental services. However, CMS believes these trends are showing signs of improvement. Among the adult Medicaid population, it is concerning that incidents associated with mental health and substance use disorder increased while less care for these issues was delivered. But it wasn't all bad news. Telehealth service use spiked nearly 2,745% during the time period examined. As you might expect, these findings should have implications for policy and practice inside the ED and beyond, even after the pandemic. Patients, policymakers, and many of your healthcare colleagues increasingly rely on the expertise of emergency physicians. There are two important opportunities ahead for you each to share your story and advocate for priorities that strengthen emergency medicine. We know that patients deserve care led by physicians. ACEP will defend patient safety by seeking to limit inappropriate expansion of nurse or physician assistant scope of practice with respect to emergency care. Our latest effort includes joining an AMA-led coalition designed to unify physicians across specialties where possible. You can expect to hear more about this as we talk to legislators, engage with reporters, and share information on social media. As conversations about staffing, scope, and safety pop up across the country, ACEP will support our state chapters, especially when there's potentially harmful legislation being discussed. If you have questions about scope of practice legislation in your state, the best place to start is with your chapter leaders. One of our top priorities is making sure that our members are equipped to address workforce challenges. You can find more information about prevailing trends and ongoing conversations at acep.org/workforce. These issues and many others will be discussed at length during our Leadership and Advocacy Conference in July. You can register or attend online at acep.org/LAC. Space at the hotel is filling fast, and we look forward to seeing many of you in person soon. That wraps up this week's Capital Minute. As a reminder, this episode and all others are available at acep.org/Capital Minute. Now, I'll be happy to take your questions. Remember, you can submit them using your Q&A feature of Zoom on the bottom of your screen. All right, questions coming in. What is the likelihood that insurance companies will maneuver to get what they want during these surprise billing implementation discussions? I think there's a high likelihood that they'll try to get what they want during these surprise billing conversations, but we're hopeful that our advocacy will help to counter that and that we'll end up in a good place where it's a fair system and each player has kind of an equal advantage in it. We are continuing to work to weigh in with CSIO and offer as much technical and other guidance as possible. Because we feel that the more we can inform them about the way that emergency care is provided and billed for and involves insurance companies and how that process currently works, the better informed they are on that, the more likely that any regulations they write will work well within that kind of present day system without upending it completely. And will also ensure that we have equal footing in those fights. What do we plan to do with a poll on data sharing? Is it still open? The poll did close a couple days ago, but in terms of what we plan to do with it, there were a lot of questions in there about how emergency physicians are hearing from their hospitals on implementation of it, and also just how the EHR systems in their hospitals are handling this, and then what specific concerns or recommendations respondents might have for this whole new system. And so we are distilling that. There's a lot of, we have, like there were multiple choice questions. So it's pretty quick for us to compile that data, but there was a lot of free text responses and we want to make sure those are appropriately distilled. And then what we'll do is we'll take those first directly to the Office of the National Coordinator who had asked us for this type of feedback. So we'll provide that to them. But we'll also probably take some of the findings and use them when we get requests from the media on something like this. We will probably use some of those results to respond to the media and help inform them about how this is kind of playing out in the real world. There's already been some media articles about the patient perspective on this in terms of either getting information or data about their medical condition before they've had a chance to speak with their physician about it, or patients that have seen things in their medical records or in the physician's notes that they don't feel was fair or accurate. So I think this is going to play out a while, and I think having data from how this has played out in the emergency side will be really important to informing any future direction on this with policymakers. So if we need to advocate for regulatory changes, now we'll have the data to do that. And then also just to kind of better guide public discussions of this. Another question. It seems like there's a ton of regulatory activity. How is CMS planning all these changes without formally announcing a leader? So there are still quite a few folks at CMS who are the career officials. They've been there a long time, and they play a really instrumental role in making sure the department continues to operate smoothly and work still gets done. As well, there are political appointees in HHS, so it's kind of like a step above CMS, and they're able to guide some of the decisions at the higher levels in order to address these regulatory activities. And then certainly like with ONC, I believe they have a political in place. So there's a lot of work that's being done. It's CMS that is still waiting for its political appointee to be confirmed by the Senate. But the work continues regardless, and we'll continue to have conversations with both the career officials and any politicals that are still being put in place. Question is, does the spike in telehealth use give more energy to efforts to make the temporary health changes put in place during the pandemic more permanent? I think it does give some more energy, but I think we need to do a deeper dive into the data, as are many others, to see how telehealth was used during the public health emergency. And I think there'll be questions about reimbursement and what might be perceived as overutilization. I know one of the concerns policymakers have had with more broadly implementing telehealth rules or relaxation of rules, such as were made temporarily during the public health emergency, if those were made permanent, I know there's concerns that people who normally might wait to go to see a doctor for something will now just go for like even the slight go via telehealth for even just the slightest, like mildest condition that they could easily wait a couple days to see if it resolves on its own. So one of the concerns is on overutilization of healthcare services. Even if telehealth ends up being reimbursed at a lower kind of level than an in-person visit, if patients are starting to kind of use these visits too much, depending on who defines too much, then there's a concern that that will increase healthcare costs. So I think having data that shows a lot of people use telehealth is helpful because it shows it can be used. But now we need to really, I think, dig in and show how it was used, and to be able to show that a lot of times it was used kind of in a proactive way to prevent a worsening of a health condition that would have been more expensive to treat, or to address things, before they got too serious and maybe even kind of save lives, things like that. So that's what we are taking a look at and making a better case for at least some of the relaxations around emergency care and telehealth. With the recently changed mask requirements, is there a sense that the public health emergency will be lifted? I don't think we're quite there yet. I know we'd heard through kind of the grapevine that the administration plans to keep the public health emergency, excuse me, in place potentially until the end of the year. That's renewed every 3 months. It can only be renewed for 3 months at a time. I believe the next time it expires is at the end of June or July. So then it would be another 3 months to then go to the end of the year after that. So we're keeping a close eye on that. One thing is that there's several issues that ACEP is working on where they're kind of dependent on the public health emergency. If it extends into 2022, then we're good for the rest of 2022. So even getting the public health emergency extended to January 1st rather than December 31st would help us on several key issues. So that's something we're keeping a close eye on. Question is, does it look like these state level scope of practice issues are picking up steam? It does seem to be right now, and I know there's been legislation in several states recently introduced that we're keeping a close eye on. And so that's one of the reasons ACEP decided to join the AMA Scope of Practice Partnership so that we could join with the others that are involved in that partnership to kind of combine tools and resources to better address these fights. Because while there are unique aspects to scope of practice issue for emergency care, there's also a lot of shared kind of issues and messaging that other specialties, other physician specialties also have faced on this. And instead of recreating the wheel, we want to make sure that we kind of capitalize on all of that. Another question, last question, I think, is coming in. What are the top issues for discussion at LAC this year, and will I be able to meet my member of Congress? So we are finalizing the issues that will be discussed. So we'll be able to preview those on the next Capitol Minute and talk a little bit more in depth about what those issues are and why we picked them. And we expect that everyone will be able to meet with either their members of Congress or their staff. That's something we arrange each year. So we'll be moving on that. And we have a number of, I think, exciting speaker invitations out right now in the field that we're hoping to be able to announce the results of shortly. And I think it really will be just a robust conference. And I think we already mentioned at the beginning, the workforce, there will be a town hall on the workforce issue where ACEP leaders will provide an update on the latest efforts on that. And then as well, LAC participants will have an opportunity to ask them questions and to sound off on their own views on the issues. So definitely stay tuned for that. It's well worth coming to LAC just for that. Just as a reminder, it's in person. This is going to be the first, I think, major ACEP meeting that's back in person after everything shut down in spring of 2020. So it'll be a great opportunity for everyone to catch back up with their friends and to network with their colleagues and just be able to celebrate being all together in one place again. So stay tuned for that. And thank you again for joining us today on the Capitol Minute, and we'll see you in 2 weeks.